Right, so my name is Kevin Teoh, if you missed me from earlier on, and I'm going to talk to you about one of my research areas, which is the working conditions of doctors in the NHS. It's quite a contextual, specific area, so what I've done is try and give you a quick overview and then some sort of quick takeaway points that perhaps might be relevant to organisations in the non-healthcare sector. And I know I'm conscious at the end of the day, so let's just get on with it. We know the healthcare sector is inherently a very difficult environment to work in. The nature of healthcare work is characterized by human suffering, emotion, pain, and death. You may have come across this picture, went around social media a few years ago, which captured the moment where a young doctor, having lost a patient, walks out of A&E, walks across the ambulance bay, and breaks down because of the nature of work. So we know this happens. So the question then is, shouldn't we have a responsibility to design a workplace, organize it and manage it that allows people to look after and safeguard the individuals who have to work and operate in such an environment? And we know that doctors are struggling. And today I'm going to talk about doctors, but this applies to nurses and other healthcare professionals as well. And just to give you some figures, this is a study that should be out in a couple of weeks, hopefully, that we did with just under 600 NHS consultants. And you see the headline figures over here, that about 40% of consultants, so these are senior doctors, currently experience higher levels of burnout and have symptoms of anxiety and depression. So in the media narrative, this is something we talk about, and the implications and the concern that we have is, what impact does this have on patients? And what are the factors that leads up to this? We know anecdotally, a lot of these relationships make intuitive sense, but the reality is actually when it comes to policy and developing evidence-based arguments, there's very little evidence demonstrating these relationships. So the bulk of my work is looking at trying to quantify and measure these relationships. So using data that we collect from the NHS, that the NHS collects, so secondary data, we try and link working conditions in hospitals with the well-being of doctors and ultimately patient care. And we see things like job demands. So the idea that having insufficient resources, being exposed to workplace aggression, but also low job resources. So poor manager support, not having job control, not being in effective teams. All this is detrimental in terms of the work-related stress and presenteeism that doctors experience. And presenteeism refers to going to work when perhaps you should be, when you're ill and you should be at home recovering. But we see the opposite relationships when it comes to more positive aspects of well-being. And I know someone mentioned the debate around work, around engagement, and I won't go into that really, but we use the term work engagement. So we see the opposite relationships over here. And what we find is we're able to quantify that the impact of working conditions impacts on well-being of doctors, and in turn that this has an impact on the patient. And how? When we look at doctors when they rate the care that they themselves feel they provide to patients, when we ask doctors to rate how they feel the hospital provides care to patients, and also the number of errors which they think occur in their workplaces. And all these are concerning things for us. And it's not just that. Other quality metrics, so such as patient experience, patient safety incidents in hospitals, are also impacted by well-being and working conditions. And when we take a step away from that, and we recognize the NHS is under pressure, some of the metrics which refer to demand, so the proportion of beds being occupied and the number of emergency admissions, not only is this high, but this has a detrimental impact on the well-being of staff and also patients. So what I've done is provide you kind of a whistle-stop tour of a number of different papers. Of course, the nature of these models and relationships are a little bit more complex, and that's a caveat that I'll add to that. So then the question is, what does this mean for us? How is this relevant to us? At a very personal, individual level, the unfortunate reality is that most of us at some point in our lives will probably end up in hospital. And should that happen, we would like to think that the hospital is being well run, that your medical staff are fit, are well, and the care that we're receiving is the best possible that we can get. But moving away from that, thinking about organizations more generally, what are some of the lessons that we think we've maybe picked up upon in some of this analysis that is perhaps relevant, that you may be able to take away? And the first one is coming back to work engagement. So I know there's a lot of definition a lot of controversy around the definitions of engagement. We use the term work engagement, which essentially refers to feelings of vigor, dedication, and absorption in the workplace. Because what we find is that work engagement is a crucial mediator that links working conditions of doctors with patient care, more so than, say, work-related stress or presentism. So then the question is, how do we increase work engagement? And from our own research and also from the wider literature, we know that it's not just about reducing job demands, but essentially it's about providing the appropriate job resources and also sufficiently challenging your workforce. And one way of doing that is through job crafting. And I'm not going to talk about job crafting because if you're not aware, the keynote which follows after this is a whole session on job crafting presented by one of the world leading experts on this, Professor Eva Demaruti. And the second thing which I wanted to highlight that we picked up is that if you are talking about change and interventions and improvements at an organizational level, involving a lot of people, it may be that if you target interventions and change with small groups of people or very specific aspects of work, you may not generate the outcome that you desire. So for example, we know that there are about 100,000 plus doctors in the NHS, and one of the things that we tried to do was to link the work experience of these doctors with hospital mortality rates, because hospital mortality rates get the attention of the Department of Health. It's something which everyone is interested in terms of impact. So we assume that there's this relationship between work experience and mortality, but we weren't able to find this. We know there's about 100,000 doctors in the NHS, like I said, but when we put them alongside their colleagues, that's about 19% of medical professionals, if you add in their nurses, paramedics, technicians, midwives, and so forth. And then on top of that, when you add in the non-healthcare professionals, so managers, admin staff, porters, kitchen workers, cleaners, and all of that, the proportion, the impact that doctors have is a lot smaller. So in hindsight, it's perhaps a little bit naive to assume that the work experience of one specific group has such a large impact on what is essentially a very complex health outcome, such as mortality. So the implication here then is that if we think I'm going to run a small-scale intervention here, and I don't know, I'm going to say mindfulness or relaxation or yoga, whatever you want to call it, it may perhaps have a positive impact on that group of people. But if you think that that's going to solve your organizational level problems, you may be in for a surprise if you're not aware of that already. The third thing is we want to encourage silos to work together, because in the NHS and in the healthcare sector, we find that agendas around patient safety, around staff well-being, don't necessarily overlap. But from our data, we see that it's elements such as high job demands, low job resources, which are associated with poor care, which are associated with poor staff well-being. So if we can address these more upstream factors, then really we may be benefiting multiple groups of people, multiple agendas at the same time. And I think sometimes we lose track of the systems perspective and coming to the root cause of what issues are, because really often they have far more in common than we may be aware of. And Wilson was talking about this, really getting what is the question and what really is the problems that lead up to that. So whether it's selection and retention in your company, or safety, or well-being, or performance, these may be under the purview of different people or different teams, but perhaps they may have more in common than we're aware of. So definitely encouraging people to have a more a systems perspective in understanding the root causes of what might be going on. In terms of moving on, building on from this research area, definitely sort of three things that I wanted to pick up. One thing is around data. I do a lot of work with data. If you give me data sets, it's like bringing Christmas into my life. So if you've got data and you don't know what to do with it, send it over to me. But we know in the NHS, in the healthcare sector, a lot of data gets collected and a lot of it doesn't really get used. So we want to link these and we want to better understand this so we can inform evidence. We talk about evidence-based management, but actually evidence-based policy making as well. And that then relates to the second point, which is about influencing policy. And some of the work which I've done, Almuth mentioned the Lewis Tebbutt Foundation earlier. I've also done some work with the Royal College of Psychiatrists, which you would think the Royal College of Psychiatrists doesn't have an agenda or strategy on how to look after the mental health of their own psychiatrists around that. And then the third is around intervention. So really what can we do in organizations and from a practical setting to make a difference from at a more local level. So if you are working in and around this area, or you're generally interested in interventions, please do grab me, and I'm happy to have a chat. So I did say I was going to keep it short and sweet, and I was conscious of time. So 3 things I wanted to highlight really is the importance of work engagement, that we should be targeting right areas of change, and that really we want to encourage silo thinking. We don't want to encourage silo thinking, we want to avoid silo thinking and encourage people to work together from a more systems perspective. Thank you very much.